Welcome to the So Why podcast with Stepped Care Solutions. So why are we excited about Stepped Care 2.0? Stepped Care 2.0 is an innovative and transformative model for mental health and substance use health care that leverages collaborative efforts and technology to transform systems for better access and outcomes. And Stepped Care Solutions exists to help organizations and communities reframe, rethink, and redesign the delivery of mental health services through flexible, open access, recovery-focused approaches. On this podcast, we explore issues and challenges, as well as ideas and solutions around how to create person-centric systems that are holistic, accommodating, and thoughtful. My name is Kait Saxton, Director of Service Delivery Strategy and Implementation at Stepped Care Solutions, and I'll be your host for this episode. My guest today is Dr. Vera Romano. Dr. Romano is Director of the Student Wellness Hub at McGill University and an Associate Member in the Faculty of Educational and Counseling Psychology. She has maintained a private therapy practice since 2000 and brings over 2 decades of experience in student mental health and wellness. At McGill, Dr. Romano leads a nationally recognized initiative that integrates physical and mental health services with a strong emphasis on prevention, early intervention, and inclusive care. McGill's Student Wellness Hub provides a range of services to support the well-being of McGill's students. The Hub is committed to supporting the diverse needs of McGill's student population through accessible services, peer support, and wellness education that reflects the university's values of equity and belonging. I'm excited to share my conversation with Dr. Romano about how McGill has approached effectively working together to support students and put them at the center of their well-being journey. Well, thank you so much for being here today with us, Vera. We're really excited to have a conversation with you, learn more about the work that you're leading and your team has been involved with at the Student Wellness Hub at McGill University. So maybe we can start, if you are able to tell us a little bit about the services that you offer at the Hub and overall the focus of the Student Wellness Hub.
Okay. So the Student Wellness Hub was launched in 2019. And it really represented a re-envisioning of post-secondary health and mental health and health promotion at McGill University. So this re-envisioning had multiple implementations. One big bucket was a restructuring, so a bringing together 3 units that were formerly separate. So we had a former health services, we had a former counseling services, and then we had a former psychiatric services. So one of the envisioning had to do with bringing all of this together under one umbrella, one structure, but really in a very intentional way, under the sort of paradigm of collaborative care model. And the collaborative care model includes 3 facets. One is interprofessional care, effective ways of bringing subject matter expertise and skills and competencies, everyone from within their own sort of professional area. The second one is stepped care. And I'm sure we'll get into that a bit more later in terms of elaboration. And the third aspect is shared care. So that was a really, really important part, but also re-envisioning, when we talk about collaborative care, it also meant that we moved away from, I think, more traditional understanding of interprofessional care. And we included in the interprofessional care really the full user experience. Okay, and really the importance of especially student co-design or stakeholder co-design in actually designing the model. And I can sort of elaborate a bit further about what that meant. However, the re-envisioning was not just a big restructuring. It also meant adding two very, very important sort of parts of the structure. And that was, we basically created a new health promotion structure in the Healthy Living Annex, which is both a physical space, but also, a whole team that is part of the Student Wellness Hub, bringing in, hub peer supporters, bringing in health promotion sort of specialists, and a variety of other kind of programming, and subject matter expertise around knowledge translation. So that is all under the health promotion sort of structure. And the final aspect of the re-envisioning and the restructure was really kind of it's almost like an embodiment that combines both the re-envisioning from a philosophy or paradigm of care as well as the structure. So we have taken basically the hub and we created a hub and spoke model. And the hub and spoke model really means that we have local wellness advisors who are mental health professionals, but are not therapists. They are mental health professionals who focus on awareness, prevention, and early intervention. And they are embedded in each of the faculties, as well as important units at the university. So, for example, athletics and varsity, for example, the residences, for example, international student services, and so on. And then the pandemic happened shortly after. So then it was about really very quickly implementing sort of, telehealth, e-mental health. There's quite a lot of pivoting and a lot of sort of co-design that needed to happen in a very, very quick way. The final aspect that I just want to name that was important is that when we implemented all of these changes, we built a pretty intentional and solid not only implementation plan, but actually accountability framework. So we really wanted to have an iterative process of measuring, planning, understanding the needs, implementing, and then evaluating, and quickly sort of having these cycles of either fine-tuning or even more macro level kind of shifting. And that is really a built-in not only for the implementation phase, but on an ongoing basis, basically in terms of collecting, feedback from users, from professionals as well. For example, in the pandemic, we did that. So that's a very important facet. But I think that was pretty broad. So I'll leave it at that for now.
That's excellent. Thank you so much. I really appreciate hearing more about the journey of how the hub came to be and all of the different levels of very intentional aspects of system and service redesign. And I love the language you use around re-envisioning and restructuring and all the things that come behind that as well. So thanks so much for that really comprehensive overview. I'm wondering if you can also share a bit about what sparked some of those changes. It took a lot to kind of get you to where you are today, but if you can think back on what really led to this this change back in 2019 and probably before that.
Yeah. I think that I would say for the probably 10 years before that, there was, I used to, before having a leadership role, I used to work as a clinician in the former one of the units. So I was a psychologist, counseling psychologist at the former counseling. I did my practicum, my clinical practicum in the former mental health, or what then became psychiatric services. And there were, I think that the model used to be, and it was a very good model for a very, very long time. It was really a model of kind of a co-op of clinicians that work together effectively, often in more separate kind of departments. The distinctions were pretty clear. And and they were able overall to answer the needs. Okay. And every year, like in the 10 years before 2019, I think there was a shift. There was a shift of more demand, maybe more complexity. The fact that there were these separate departments, it was kind of being questioned in terms of the kind of the journey of the user, like, right, of the client, and the student. So we were getting more and more feedback through different channels, right? It could be through student media. It could be through, the different governing bodies of the university, student associations that, more demand, more wait times, more people experiencing the separateness as aversive, as being kind of bounced off or being lost in the shuffle. So the expectations also, I think in terms of a standard, of the experience has shifted. I think there was, with the introduction of things like, the smartphone and, social media, and there was a sort of a variety of kind of big societal changes also that have been happening. And I think there was an expectation or a desire for more specialized care, that like something that kind of works for you. There was also a lot more access to things kind of online, right? And some of this was really great, but some of it is actually not so great. Families, parents of post-secondary community, were giving us feedback that there was a need for more. And we definitely have seen, I would say, in the 5 years before, so like since 2012, like a real sharp increase in wait times, in demand for services, as well as in complexity or distress level. I would not say that we had the evidence to show that diagnostically there was a true increase in sort of a mental illness as an epidemic, but we definitely saw that around certain things, like especially anxiety, but other things as well, that there was definitely increase in the stress levels. So as well as, challenges with functioning, like impact, it's not only just a distress level, like we were seeing, I think a need for students to feel more scaffolded in their transition into university, and their experiences in the university were being experienced. The pressures were experienced not often in the way that made them feel like they're empowered to kind of like, rise to it, but actually that they're overwhelmed by it. So I would say that these were all sort of the kind of background experiences that I think McGill was certainly not alone with this, right? Like we were doing benchmarking studies and kind of population kind of surveys and participating that. So there was a lot of discussion on a provincial, on national, North American, as well as international. Like this was a phenomena that was really shared in many of our peer sort of institutions. And I think another thing that was shared is that our previous solutions were really kind of same paradigm, but more of it. So trying to get, let's say, more counselors, more psychiatrists, more of the service providers. And I think that also, at least at McGill, and I know that like others have reached a similar consensus and conclusion that doing more of the same was actually not working. And we needed to actually sort of really kind of think more broadly, like big picture, not just more of the same.
That's such great context, and I think really adds to the richness of that history and that journey that you shared. So thanks so much for sharing that. And what I've heard a lot throughout the conversation already is many of the aspects that really resonate with our Step Care 2.0 model as well. So thinking about those terms that you mentioned around a paradigm shift, and from the way the system's designed with more collaboration, co-design, thinking more broadly about the workforce, and then from a client experience, having more access, different types of services, that health promotion, prevention, really important upstream factors. And so I'm wondering if you can share a bit about how the Step Care 2.0 model informed and supported both the services that are offered within the hub and also the process of that development of the hub as well.
So it informed it significantly. But, as life unfolds, not always in the most predicted ways. And what I mean by that is that we actually started the implementation of stepped care before the hub was launched. So the 2 years before the hub launched were already kind of a smaller scale reorgs. Okay. So basically, there was 1 year that former counseling and former mental health joined to be counseling and mental health. So we had like 1 year of that. And then we separated out the psychiatrists from that and kind of went back to kind of separating out psychiatry. As we were doing that, at the same time, we implemented also stepped care. But, our understanding at the time of implementing stepped care was, I would say, really well-meaning, but a little bit naive. And I think naive from the perspective of sort of naive both academically from a scientific approach, but also naive a little bit clinically. So what that meant was that, I thought I was part of the leadership team, along with others, that this seems where the evidence is really leaning towards. So let's bring, sort of Peter Cornish, and who at the time, was at Memorial, and, Anne-Marie, and let's have trainings. And we really thought that having trainings is going to be really at the heart of the implementation success. And that was happening while also we're dealing with a lot of change management and cultural management around the climate, around, all these, changing the structure, which is not, it's not necessarily easy or difficult. I think it just depends on, how the system is in that moment, but it is a change. So I think that the early experience of stepped care was, implementation of stepped care was, suffered a little bit from our naivete. And I think that what happened around, we still implemented it, right? We implemented aspects of it. And it also became clear that we were still not integrated fully as an interprofessional team. Okay. Health services was still apart. Counseling and mental health had two separate leadership structures. So it was sort of a little bit like, I don't know, like a centipede that is kind of like attached to each other, the legs, but we're not all aligned really. And it was a little confusing, I think, for people as well. As well as I think that it probably, if I go back and ask folks that experienced it, the professionals, I think it probably was experienced a little bit too top down and not really kind of co-design enough. Definitely from a student perspective, right? Like we kind of announced it, and And even though we did have student voices even within that, but it was not enough. So I think that having the whole recalibrating with this big re-envisioning, okay, and it wasn't kind of in the middle, like we're kind of together, but we're not together. We're like it just sort of, I think, created a sense of like a little bit shock to the system, okay? But I think that shock also was an opportunity to really kind of practice system flexibility, right? And we also at that time connected with Alexia, who happened to be, a colleague from our PhD days, but she was at the time, not in step care, in another institution, but she brought forward this specialty of implementation science, which frankly, I knew nothing about. I think our approach so far up to that point has been really to look at the implementation more like from a business project management perspective, and change management perspective from that approach, which is informative, definitely. But I think the implementation science coming more from an educational background and us being post-secondary, I mean, at the end of the day, the Student Wellness Hub is not a hospital. We're not a CUS. We're not a CLSC. We're not a public health sort of institution. We're here to support the educational mandate of the university and to support the educational success and flourishing of our students. So I think having that educational kind of background for implementation science was really very, very interesting. So we brought Alexia, we did some training, some coaching, and there were also a lot of insights through these trainings and coaching, because one of the things we actually was really an eye-opener. Yes, training is important, but it really is a relatively minor part of the, contributor to positive outcomes. And the importance of coaching, which is a much more broader pedagogy, right? That includes a lot more experiential aspects, but also recruitment. And that was really, really key. And and during that time, I think the shock to the system also meant that, there were, professionals that really sort of face this decision of, it's very clear that this is the direction we're going. This is what we're doing. There was no more ambivalence about it. It was kind of, it was clarity. Clarity is kindness, I think. So clarity's helped individuals to sort of either to sort of like kind of find another path for them, like a better match for them. Or really kind of engage with the, co-re-envisioning, okay? And, and in a variety of ways, like it's not, not everybody in the same way. So, so that was a very big catalyst, the implementation care, the implementation science, kind of like that being, a bit of a paradigm shift. The final thing was the pandemic. The pandemic really brought forward an aspect of stepped care that that was, in terms of like readiness for change, I think that the community at large or the society at large was a little bit in a pre-contemplation stage or maybe contemplation stage. But, with the pandemic in 5 business days, we moved all of our professionals to telehealth and telemental health. So that was really very big, shift, and and that upstream that you're talking about, a lot of it sort of involves also re-envisioning what you mean by providing care, right? In terms of the structure, like the length of the session and the modality of the session. So I think that was very, very interesting and very positive. And it's I think probably before the pandemic, if you would ask people, that we have overall high 80s, like 88 and even 90s in terms of user experience satisfaction with like e-mental health and e-physical health. There's certain aspects of the care that e-health and e-mental health actually has a higher levels of user experience. And we have very high engagement and buy-in from both the professionals, all of the levels of the professionals, and students. Now, of course, we've been post-pandemic a little while. So like, well, in the beginning, it was like 90, it was actually 100, but then there was pivoting. So it kind of was like 90-10, and then it became 70-30. And then now we're like in the, in like the, like 60-40 for the physical health, kind of 50-50 for the mental health in terms of in-person or e-mental health. So I think that was a very, very interesting, as challenging as, of course, the pandemic was. Like that kind of shock to the system was really opened our eyes to what is possible, like for ourselves, and of course, the notion of programming, what it means to have programming, I think before the pandemic, our understanding in like the things like workshops, was very kind of traditional model. Let's on a Tuesday at 4 have a stress management workshop, or, or like anxiety management, or, and we have introduced already quite robust needs assessment based, evidence-informed, evidence-based programming, right? But with Step Care, with the hub being launched, for example, we really resourced certain steps, like therapy groups really invested in the training, again, coaching, recruiting, bringing in-house, building on in-house kind of specialization and skills, knowledge translation, and so on. So we really invested in that. But, if you put all of that and you say, I'm going to put it at Tuesday at 4, you're going to get the students that can come at Tuesday at 4. And, it was sort of, so all this idea about the difference between things that are available in an asynchronous way, and what needs to be like reels and what needs to be, social media, that was again the lead at the time of the health promotion group, was really kind of revolutionized that. And we have launched our Instagram, Healthier McGill. And a lot of it was kind of like, challenging for her, because again, for me, like as a professional, I'm like, I don't know, like the notion of us being able to effectively do awareness or prevention even on Instagram was like unthinkable. I could not even imagine that. Like, and not only that, it felt a little offensive. So it kind of shows you how old school I am. But, and she, and again, we did it carefully, we did it with safety. But for example, some of the programming, like we had these lunchtime kind of like meditations, like, but various forms, like nature walk meditate. And it was like, I think it was like maximum 10 minutes. It was more like 5 minutes even. At the time, I think it was a YouTube video or I have no idea. It was something in social media, but I don't know what it was. I don't remember it. But we had thousands and thousands and thousands of like uptake on that, because it kind of talked to people where like we were all kind of like, we had something with like meditation with your child, because like, people were working from home at times and the children were here, and, so we were all feeling isolated. And so the importance of, like going out and getting some fresh air, or anyways, all of this to say that I think the combination of Step Care implementation, lessons learned, implementation science, pandemic crisis that turned into opportunities, and a true sort of collaborative care approach also to leadership, Like, I think that those were things that were really helpful to our step care implementation. Like, it's too big. I think it needs to be held by like a collective. It can't be just like, one person who really believes in it and is like a guru or needs like, it just doesn't work. At least it did not work in our, context.
Yeah.
Oh, one thing I forgot to mention, a big shift, leadership support, so important. I should not have forgotten it because
we could pick up on that. That's a good segue, actually.
Go ahead.
I really loved the framing of that collective, and that this can't be held by any one person. Maybe it's championed by a number of people and kind of built on that in an ongoing way, but that it really does take a collective of a diverse workforce, leadership, clinical experts, knowledge translation, communications, all of those things that you've mentioned. So many people are really at the heart of that transformation. And that can be really challenging at times. It can be a source of a lot of energy and opportunity, and I think probably oscillating between all those things. Yeah. So I'm wondering what kinds of adjustments maybe service leaders, administrative leaders, clinicians, others had to make to really support and bring this transformation to life.
Because it definitely was a journey. Like that creation of what I feel now, we're a very kind of steady collective in terms of a leadership, and mutually respectful. And there's a lot of clarity about roles and responsibilities. And it is also held in a very steady senior leadership ecosystem in terms of support. Okay. And all the way, like it's at all levels. I feel like it is pretty harmonious, collaborative, steady. It required, I think, a lot of courage. So courage in the trying, risk taking. Like I think that, but informed risk taking. We really had to prove ourselves.
Yeah.
Because while now there's a lot of alignment between our model and both provincial and national protocols and standards, and kind of best practices, when we were first doing it, it was not really it was not tested fully. I mean, I think pieces were it, but it was not tested. So it meant taking risks. I think the risk-taking early stage of implementations was, but what is the right pathway to a solution? And when that is sort of the environment, you have to have managers and leaders and at various levels that are willing to try things, that are willing to, that have a very high degree of openness. And also that there is a building of a shared trust. Okay, because if you want yourself to take risks and try things, it has to be something that is shared responsibility, right?
Yeah. And it sounds like things like courage and that informed risk taking and shared vision amongst certainly the leadership and senior leadership team, but probably throughout the hub and the service providers and engaging more broadly as well. It was probably really important to that. And so I think that's something we hear a lot about too in implementation science. And when different communities and organizations implement the model, is that it's often not a linear path either, and that there's starts and stops and more motivation and less at certain times. And being able to recognize that and change approach, be very flexible, which I've heard you speak a lot about flexibility throughout that, I think goes quite a long way. So
yeah.
Were there any challenges that you faced, recognizing it wasn't an easy journey, as you say? Were there challenges that you faced around increasing that interprofessional collaboration or implementing certain aspects of the care that you can think back to now as some lessons learned, or maybe ways that was strengthened, that interprofessional practice piece?
Do you know, like how when there's these studies about psychotherapy integration, like you can work from you can work from a cognitive model, you can work from a behavioral model, you can work solution, you can work narrative, but some theories are quite challenging to integrate because their foundational worldview is a little opposing, okay, a little or a lot. So, for example, if you have a very pessimistic view, or one would say realistic view of human nature, it's going to be more challenging to integrate with a theory that has a very positive nature of the human nature, right? Or if you have like if you think change is quite easy and can be through reinforcement and reward and so on, can be, it's malleable, it's one thing. If you think that it's all very unconscious and very unavailable, it would be harder. So when you try to bring together things without thinking about their roots, it makes it just like a hatchpatch of things.
Yeah.
So we took a lot of time to, for example, we have a leader in the hub. So the associate director in my leadership team, one of the associate directors is associate director of collaborative care. So we actually invested a resource on that. She's with us part-time because she also has another clinical hat elsewhere. But her whole job is to think through how we implement collaborative care in a leadership at all levels of the hub.
Interesting.
So from hub peer supporters, from frontline, from, primary care, from psychiatry as a specialty, from our dietitians, from our nurses, from our counselors, our case managers, our local wellness advisors. So that is number one, to give it the intentionality and the resources. And she has experience with stepped care. So it really allows her to understand that it's not just about trying to bring people together and just kind of get along. It's more than that. You really need to kind of understand the philosophies of care that people bring, the social sanction that they are used to. And we really wanted to honor people's subject matter expertise, but we also wanted to make it as collective, as non-hierarchical, as sort of collectivistic as possible. And when we did that, I think that was much better, right? Like much better around when we launched the hub. One of the first interprofessional implementation was about how do we deal with walk-in crisis, okay? Because walk-in crisis kind of like was happening, popping up all sorts of places, and we wanted to make sure that it gets integrated and that we're quite intentional about the safety of our community and crisis management and so on. So what we did is that instead of giving it to only the psychiatrists, right? Because in the former mental health, like that was or only the counselors, we said we have a lot of expertise here. We have nurses, we have social workers, we have GPs, we have psychiatrists, we have counselors, and so on. So we created this, and it was Patricia's, I think, the first big project around how to make us an interprofessional team was around creating an interprofessional approach to crisis management. So we said, let's do that. Let's make sure we also invested in training, because not everybody, not all the nurses had a background in training for around that. So we did the appropriate trainings, very intensive, very proper pedagogy trainings. And then we had this room at the main floor of the clinic, and it would be scheduled by all of the different professionals. And we knew that basically these crisis kind of walk-in situations would be handled there by whoever was on call, but they would be physically there. So it could have been a psychiatrist, it could have been a counselor, it could have been a nurse, But when I say that, it was not easy for people. It was not easy for people who are used to work, in one room, that they have, like, it represents their structure, it presents their professional identity and their comfort level, their, to leave that room for that function, and to go down to work for 2 hours from that room. It's sort of like, it created this, it felt like a bit like a kibbutz experience. It felt a little bit like we're all in it. Everybody is like doing it. Yes. So it wasn't always easy, but I think that the team really responded to it very, very well. And it didn't take much time for all of our professionals to rise to that occasion, But
Amazing.
But also the lessons learned was, once the pandemic happened and we're mostly online, or a lot of it was online in the beginning, we created a protocol that was mostly online. And then we also increased the resources in case management, because we didn't have case management before the hub was launched in any meaningful way. So now we have a small team of case managers. And actually we decided, like, lessons learned around how it's going, that it actually is better when that whole function, when it happens in this, like, walk-in kind of way, is better managed with that team as a specialty of, but it wasn't because the other kind of more fully collectivistic interprofessional approach, it wasn't because it didn't work. It worked. But now, like, it's also, we have much less walk-ins because we have moved post-pandemic to completely, like, all of our appointments are pre-scheduled. Even if it's same day, like we have GP appointments same day, it's pre-scheduled. We don't have walk-ins anymore. So anyway, so it was a bit of a long answer to ask you about to answer the challenges, but
yeah, it's a complex question. So I think one of the things that I'm really hearing is also the intentionality of it, and recognizing that people are coming to this from their own professional backgrounds, their own training, their own experiences, and that their identity is really tied into that as well. Of course, people come into this profession because they want to do good work. They've been trained to do good work. They really care about the people that they're serving and the people that they work with. And changes to that can be really difficult, but ultimately I think that intentionality around it, that thoughtfulness, that continuously iterating that process and what that looks like in context is something that sounds like it was a successful strategy for you. So, and thinking about the other part of this change, of course, this presents changes to how providers are engaging in the system, but ultimately, what's really driving this is the outcomes for students. And you said that right at the beginning, is really being there to serve and support students in their educational journey, flourishing, well-being in the university context. So I'm wondering if you have any anecdotal or other types of data that speak to the impact at the student level and maybe even the provider level as well.
One of the first things we have done early stages of the implementation was actually try to assess as much as possible whether we have implemented what actually we were like meaning to implement, sort of using the sort of quality improvement kind of cycles, like those kind of like mini kind of cycle implementation. So that is like one aspect of it. The other aspect of it is that we have ongoing sort of surveys for all of our service providers, right? So basically once a month, student users get sort of our survey about their user experience. And again, I keep trying to not to use the word satisfaction, because we have really moved away from understanding our accountability framework from kind of more narrow satisfaction or not satisfaction to actual fuller EDI informed and so on, user experience, right? So we're looking at things like whether the student felt, easy things, they were easy to navigate, things were clear, like those kind of things. But indicators of outcome, like middle level outcome predictors, like more alliance type experiences. So whether they felt respected and heard, whether they felt safe, whether they felt they were treated with dignity, whether they had very clear steps about next steps, like so the alliance kind of goals. tasks and goals, as well as kind of more bond and more sort of kind of overall climate kind of feel. So from that perspective, since the hub was launched, so now we have 7 years of these, the trend of the numbers in terms of impact is very high for those aspects, okay? From the experience with the provider, as well as kind of more even the user experience with customer service. Like, again, one of our re-envisioning was to ensure that every contact feels like the right door, right? So it's not just the specialty door of psychologists or counselors or psychiatrists or nurses. It's also the front line. It's also the greeter. For example, the first point of contact for our students is actually a fellow student. Our greeter, there's a greeter booth. They don't, of course, have access. They don't do registration, but they're there to navigate because we're a complex system. Even physically, we're not it's not always easy to find. But if we are unable to provide them what they need, so there is a student greeter that has a little one of those things,
like a tablet,
yes. And you help to kind of navigate and to help the student to maybe get somewhere else, either at McGill, another service at McGill, student services, or elsewhere in the community. So so the fact that like everybody is like part of the same it's the collaborative care is, as I mentioned, it's just like every step sort of the way. Well, in terms of outcomes, I want to just mention one area that has been continuously highlighted as an area that needs improvement, and that is our appointment booking experience. So at present, our appointment booking experience is still mostly by phone. So that has been, and now we're in call for tender for a new electronic health record, which will have a full functionality. We need also online appointment booking. So that is something that the outcomes keep giving us like that feedback. But it also gives us an opportunity to see if what we're implementing is working, right? Because initially the appointment booking experience was negative, even if it was on the phone. Okay. Now, actually, the user experience on the phone is very positive. They feel they're treated with politeness and civility and empathy and all of that stuff, right? So, because we knew it's so frustrating for students just to begin with to deal with the phone, so we worked a lot around quality improvement in terms of like of our like sort of our frontline and operations team. Okay, so that's a good example. The other outcome that is still keeps coming back and it continues to be a challenge is our capacity for GPs, primary care, and the introduction of primary care in mental health in our site has been one of the biggest successes. The collaboration, when they were separate, because we had psychiatrists, our GPs would not touch mental health. But that is not aligned with how things are in the community, right? The role of primary health in mental health is very, very important, and is very much at the heart of stepped care.
Absolutely.
But in order to build that up, we needed to have like shared care and consultation and all of that stuff between those interprofessional groups. But we still don't have enough GP capacity. So it's the group that provides the highest number of appointments per year, but the feedback is the worst, not about the experience. The experience with the GPs is wonderful, but it's the delta, the gap between what the community needs in terms of service providers and what we have in our environment is very, very big. So that is something about outcome. And again, we keep, for example, based on that feedback, we just hired a nurse practitioner, which really helps with primary care. You keep adding the areas that you optimize, the areas that you can control. I mean,
Absolutely.
But it's like, we can't control everything.
Yeah, kind of that spirit of continuous improvement, gathering feedback, acting on that data, the insights that are gathered. And it sounds like there's a real focus on people's experience in the service from every point in their journey, which I think is a really important part of client care and student care. And so really nice to see that. It's been a positive experience overall for folks accessing.
Yeah.
We'll close out with one more prompt or question. And you've shared so much today with us, Vera. So thank you so much. And the richness and the context that has been part of the journey of your implementation at the Hub, I think is one that there's so many learnings for different post-secondary leaders, community leaders, service providers. And so wondering from your perspective, for those that are listening to this conversation, what might be one change that you would recommend or that you think has a lot of potential for post-secondary schools that they could make to begin really unlocking the full potential of their well-being resources on campus?
You're challenging me. I'm not a minimalist. So 1.
It could be 1+ if that one is quite tough.
I'm going to do 3.
Okay, love it.
The first one is make sure that you embark on this journey with enough support from both senior administration, but also, we were very, very lucky to have a foundation that contributed and injected a significant donation, and it was a collaboration, of course, with McGill, but also financially with them. And we couldn't have done it. Like, we couldn't take all of this on, without that. Now, it does not mean that if you don't have, because what I described is like a full, like, we have really re-envisioned everything in some way. But it does not mean that if you don't have that kind of ecosystem, full support, resources, and so on, that you can't do anything. Absolutely, that's not what it means. So I think that what you can do anyways, regardless of, the first one is to re-understand and redefine what we do as it takes a village. It's a community. It's a whole campus approach. It's a community. I think that if it just is, a wellness hub or a health service or a counseling service, or, try to reach out to partners, we're not going to get everybody, on board every, day one. But, we had such interesting collaborations. One of the collaborations that is the most successful came from our teaching and learning services. Our teaching and learning services have introduced us to somebody who was a leader in academia. She was a former dean and professor, and she was doing animal sort of therapy, but visits, to hospitals, whatever. And we collaborated, and it was like an odd thing because we're like, okay, they're not employees, they're not, a vendor, it's a volunteer thing. How we're going to do it? It was complicated, but it's our really the highest level of impact in terms of programming is our animal therapy.
Amazing.
Okay, it's like thousands, and everybody loves it. Well, there people are also who are allergic and are scared, so you have to be careful about that.
When possible.
It is well loved, exactly. I should not be so absolutist about it. We're even thinking of introducing a cat now, so that's hilarious.
I would love that.
And cute. I would love that too. I'm a cat. I love both. So this reaching out. People have ideas. They have ideas about. We had some ideas about nature walks that came from our McDonald campus, or. So I think to re-envision not only like it takes a village, but be open to these collaborations, like with places like athletics and varsity or whatever expertise exists, organics, maybe small, with faculty. I think that those are really, really helpful. And I would say, I think the third is a bit more pragmatic. I think the hub and spoke model, the local wellness advisors, can be done in a variety of ways, right? Like we really scaled it up. We started with 8, now we have 23. I mean, that's really, really big. It requires a lot of resources. But to re-envision this notion of embedded counseling, because that existed, like that pre-existed the hub. There are other places that have done it. But we really re-envision it as not embedded counseling, like from a clinical perspective, but it's more around awareness, prevention, early intervention that is in the community. I think that is, like, that's where number 3 and number 1 connect. Because we need to get outside of our offices and wait for students to come to proactively build awareness, prevention, early intervention. And that by osmosis happens a lot more naturally when you have that synergy of, you have a local wellness advisor that is part of the hub, but is, embedded in a faculty and is there collaborating with the advisors and is, can do some trainings and workshops and so on. I think that there, like, it's like the impact is like, there is like a ripple effect that happens, I think in a powerful way. And I know, some institutions that have done that, with not a lot of resources. So they kind of have more, instead of embedding like one particular resource, they embed maybe like sort of anybody from, not anybody, but like maybe one day is actually somebody from CAPS, Career and Planning Services. Maybe somebody's from like chaplaincy and spirituality. Maybe it is one day from their counseling service, maybe it's a nurse, but it's this notion of us being out in the system, but not just out, like it's not about out there and then seeing one-on-one clients in the exact same way, that we're doing.
Yeah.
Like that's just a hub and spoke from a geographical perspective. That's not really a full hub and spoke. So I would end on that.
I'm really glad you expanded to 3 from that initial question about one piece of advice or insights, Vera, because I think those taken together also really do highlight a lot of the points and really bring to life that idea of what is collaborative care, what does it mean to be student-centric and person-centric, and how do these integrated and interprofessional models actually look in practice, and what are some of the ingredients that lead to success over time. So very insightful, of course, and as always, thank you so much. I really appreciate all of the insights that you shared and how candid you were in this discussion. Obviously, it's been a long journey, and the journey certainly continues, but it's so great to hear about the successes that you've had from the provider perspective and also the experience ultimately of students accessing care. So thank you so much.
Thank you, Kate. Always nice to
pleasure.
connect. Thank you.
Wonderful. Our guest today was Dr. Vera Romano, Director of the Student Wellness Hub at McGill University. For more details on the Wellness Hub and other key items we discussed, please find links in our show notes. I'm Kait Saxton, Director of Service Delivery Strategy and Implementation at Stepped Care Solutions. Thank you for joining us on this episode of the So Why podcast.